is Shawna Feely. Shawna is a licensed genetic counselor with the University of Iowa Healthcare, and she's going to be presenting on our next topic, which is gene therapy. Hi, Shawna. Thank you so much for being here.
So my name is Shawna Feely, and I'm a genetic counselor with a specialty in CMT. I was at the University of Iowa until recently. I worked with Mike Shy's team there and helped with the Inherited Neuropathy Consortium. And I moved recently to Seattle Children's to help build a research and CMT clinic there as well. So I'll touch base a little bit about the Inherited Neuropathy Consortium and some of the research that's going on there. But the main purpose of this talk was to kind of address some of the questions related to genetic testing, access to genetic testing, what types of tests are out there, CMT classifications, and then how genetic testing can impact you. We've heard some of those as well already about being able to be involved in clinical trials and things like that. But there's also other reasons that people end up doing genetic testing. And then we can talk about some of the considerations of that. So what is CMT? And I'm kind of back up. I know we had some information about that already. When we think about CMT, there's kind of two main groups that we think about, those that are demyelinating, so affecting the outside part of the nerve primarily, so a problem that starts in the myelin. And those are kind of lumped together in a classification we call CMT type 1. And then those that are axonal, so where the problem starts in the axon. And so we refer to those as CMT type 2. So type 1 or type 2 are not better or worse than one another. They're not kind of stages or anything. It's just like where the problem is starting in the nerve. And you can see a variety of clinical presentations with both of those types. As the previous speakers mentioned, there's over 100 genetically known forms of CMT. And if you include additional forms of inherited neuropathies, including sort of what we call complex CMT, where CMT and other features, you can easily get into the 200s. But we still do not know all the genetic forms of CMT. And so I saw in the comments from the previous speakers, some people who've struggled getting a genetic diagnosis. That's not uncommon, especially for people who have an axonal form of CMT, where we simply don't know all the genetic causes for those types. So I like to think of CMT as kind of like an umbrella term that captures a lot of different types. It's not really just one disease. And we start to narrow down the type by the way it's inherited in a family, as well as, like I said, how it's affecting the nerve. So there are dominant forms, which were mentioned before, where if someone has it, they have a 50% or a 1 in 2 chance of passing it on. Those can be demyelinating, which again are type 1, or axonal are type 2. There are also X-linked, so changes on the X chromosome that can lead to CMT, and so those are often referred to as CMT type X. And then there are recessive forms, which can be demyelinating or axonal, and they're referred to as type 4. There are many different other historic classification systems that are really been transitioned out or not typically used anymore because in the advent of genetic testing, we're better able to define the genetic cause for these types of CMT. And when we define them based on clinical presentations, when genetic testing got started, we realized that there was a lot of different types, genetic types, that could lead to the same clinical presentation. An example of this is some people may have heard of CMT type 3, also known as Desjardins-Sotos syndrome. When that type is described as someone who has like an early onset severe form of CMT, but when we started testing people with CMT type 3, some of them end up having a mutation in MPZ or another one in a gene called MFN2. And so that kind of got broken out into some of these sort of subtypes that are really defined more by the genetic cause than the clinical presentation, if that makes sense. So once you get sort of a number like CMT type 1, that is still just describing that it's dominant and that it's affecting the outside part of the nerve, the myelin. But if you get genetic testing and it tells you the specific genetic cause, that's when you receive like a letter at that diagnosis. So 1A, the most common, 1B, each of those designates a different genetic cause. As we said, there's hundreds. This is an outdated picture, but there are literally hundreds of different types of, CMT. So it's quite complicated. It's not one disease. That's why you can see differences in part with progression and age of onset. You see different symptoms in terms of like the pattern of inheritance, severity, as I mentioned, and selecting the right genetic test for an individual may not always lead to answers, and it can be complicated. Genetic counselors like myself are here to sort of help families walk through that process. So this is just kind of going through the main modes of inheritance that we see with CMT. As I mentioned, there are dominant forms where if you only need to change in one copy of the gene in order to show symptoms. And so if an individual has this form of CMT, there's a 50% or a 1 in 2 chance of passing it on to each of their children. There are recessive forms where an individual would only be affected if they have changes in both copies of their gene, affecting both copies of the gene. And then there are X-linked forms. And so the pattern of inheritance can be different from family to family, depending on how that type of CMT is inherited. But within a family, the inheritance method does not change unless we've heard there's some people who have multiple types of CMT, but typically for most families, this is not going to change. So one tool that we use as a genetic counselor is called a pedigree, which is essentially taking a family history. And in the context of taking a family history, there's different symbols we use. Women are designated, or people born female are designated as circles. People born male are designated as squares. So sorry, guys, you're squares. And then the people who are affected typically are colored in as an individual who has symptoms. So in this case, you can see someone in every generation that's affected. If someone did not inherit CMT, they can't pass it on. And we also see a pattern of male to male transmission. So a male passing it on to another male. So in this case, we would describe this as dominant inheritance. And then we use commonly nerve conduction studies. I know it's everyone's favorite test to look at how the nerve is being affected. So this looks at both the strength of the signal that's being conducted and the speed of the signal. So this is the test that you may have had where they put stickers on your arms and legs, and they're measuring the speed and strength of the signal that's being sent down the peripheral nerve, which is the nerve that leaves the spinal cord and goes out to the hands and feet. And in this case, you can see the speeds are listed here, and they should be about 50 meters per second. So these are all slow. So this is an indicator that the problem is starting in the myelin, the outside part of the nerve, because the myelin helps to control the speeds of our signals. So if the myelin's not working, then you're going to see slow nerve conductions. So these are about half of what they should be. And this is a very classic example of what we see with CMT type 1A, the most common type. So again, narrowing down what type a person might have. In this case, it was dominant based on the family history, demyelinating because of those slow nerve conductions. And that's where we find the most likely genetic cause being CMT1A, which is caused by a duplication or an extra copy of this gene PMP22. So whether you're male or female, you should have two copies of that gene, which is located on chromosome 17. So one from mom, one from dad. But people with CMT1A have inherited a complete extra copy of that PMP22 gene, and that tells the cell to put too much of that protein into the myelin, and it disrupts the myelin. So our goal in terms of gene therapy is to be able to sort of knock out or turn off that extra copy of the PMP22 gene so that the correct amount of protein is going into the myelin to help myelin function. And in this case, as you can see, on one chromosome, there are two copies of that PMP22. On the other one, there's one copy. So every time this person had a child, they were either going to pass on the chromosome with the two copies, which would then mean that child had CMT1A, or the one with the one copy, meaning that child would not have CMT1A. So that's where that 50% or 1 in 2 chance comes in. There are other types of CMT, and so not all CMTs occurs because of a problem of dosage, which is like extra or missing genes. There can also be changes within the genetic code itself. So on our chromosomes, which are just packages of genetic information, the genes are structured along these chromosomes. And you can think of genes as sort of represented by a code of letters. And it's a very simple genetic alphabet of just 4 letters, A, C, T, and G. So those letters are strung together in 3-letter genetic words that spell out to the cell, this is what you need to make. So each 3-letter genetic word is specific for an amino acid. And so the cell reads that and knows which amino acid it's supposed to create. And then those amino acids are strung together like beads on a string that make the proteins that function in our body. So you could have, for example, a single letter change that tells the cell to make an incorrect amino acid at that location. And that can lead to an abnormal protein that would change the function of the nerve. You can also have missing letters or duplicated words, and that can also result in a protein change. So with genetic testing, we're trying to look through all of this information, find that needle in a haystack, that little change that could be leading to the symptoms that that person is having. But genetic testing, just like CMT, is not just one thing, and it can be complicated to know what genetic test you've had or what test is best suited for you, things like that. I kind of like to think of genetic testing as a spectrum from sort of narrow to broad. So, for example, a very narrow test would be if someone knows which type of CMT they have in their family. And so we can specifically just test for that change and find out who has that type of CMT and who doesn't. So in that case, we're even looking at a single gene or even a known mutation, a specific mutation, and narrowing it down to just that. There are also what we call gene panels. These are a collection of genes that can all result in a similar clinical presentation. So there's many different labs that offer genetic testing panels, from panels for people who have seizures or panels for people who have autism spectrum disorder. And in this case, there are panels for people who have CMT. Every lab has its own selection process. And so the panels vary from small, like maybe only 4 genes, to 100 genes, to even a few hundred genes. So it's if you've had a panel before, a genetic testing panel, they're not always going to be the same. They're going to vary in size and which genes are on there. And in fact, gene panels change from year to year as new genes are discovered. Labs will add genes to their panel. So if you've had a genetic testing panel and it's been a while, we recommend considering retesting every 2 to 5 years if you've not had a diagnostic test that tells you an answer for your symptoms. We can then move into more broader based genetic testing, and this includes what we call exome sequencing and genome sequencing. So exome sequencing is testing all what we call the active genes a person has. So all the genes, the segments of the genome that actively produce a protein. So there are about 20,000 genes. So that's what exomes sequencing is doing, is testing all 20,000 genes a person has. However, there are surrounding information, genetic information that surrounds those genes, and that's part of a person's entire genome. A lot of that we still don't understand yet, but you can get genome sequencing as well, and that's also considered a very broad-based test. So the 20,000 genes that I mentioned as part of exome sequencing is actually only about 1% of a person's entire genome. So you can see genetic testing can get very broad. And there are some genes, as Allison was talking about, the new gene that was recently discovered called SORD, S-O-R-D, neuropathy. Those genes don't exist yet on panels. So you only would be able to be detected typically by doing broad-based testing like exome or genome. Again, like I said, many different genetic labs out there. It's hard to know which one is right for an individual. And that's why genetic testing or genetic counseling can be informative for families to kind of guide them through that testing process. So labs differ in cost, what insurance is accepted for coverage, the genes that are on those panels, and the number of genes. Panels change from year to year. And again, shout out to my colleagues and genetic counselors. So what is the role of a genetic counselor? So we help people understand and adapt to the medical and psychological and familial implications of genetic contributions to disease. Our national society is called the National Society of Genetic Counselors. And there you can also, there's a search area where you can find a genetic counselor near you. We help guide families through the testing process and facilitate the most effective way to approach testing that's the most likely to get what we call a positive result or an answer to someone's symptoms. And that's based on their family history and clinical presentation and features like that. We also go through the pros and cons of testing. Genetic testing isn't right for everyone, to make sure that individuals can make an informed choice. And then we help to interpret the genetic testing information, as it's not always straightforward. And so sometimes it's more complex and people need assistance kind of understanding what that means. So some of the pros and reasons why someone might get genetic testing is to determine if other family members are at risk, for family planning options to be able to prevent passing it on to future generations, possible access to treatments and clinical trials, and then just having a definitive diagnosis. Sometimes just there's value in just knowing, what is this? Why is it happening to me? Especially after years of living with a chronic disease. So there are family planning options to prevent passing CMT on to future generations, if that's something that is interest of people. That can include ways of having your own biological children while still preventing passing CMT on. These can include testing during pregnancy or testing before pregnancy. You would need to know the genetic cause in order to have these options. And there's differences in cost and things like that. So during pregnancy, you can test as early as 10 weeks with some tests like chorionic villi sampling. And then you would decide whether or not to terminate a pregnancy based on that information. Before pregnancy, you can use the same techniques that couples use when they have difficulty getting pregnant, called IVF, or in vitro fertilization. And then you can test the embryo for the known genetic cause that's in the family. And then you would only implant embryos that are not affected by CMT and carry a pregnancy that you know is not going to be affected. There's other ways that people, of course, grow their families as well, such as donor options, embryo adoptions, and traditional adoptions. And in those cases, you don't need to know the type of CMT that you have because there's not a biological relationship. As some of you have experienced, because I saw on some of the chat questions, sometimes you can do genetic testing and still not have an answer. And what then? Where do you go from there? And there are, as we saw from the earlier talks, gene discovery platforms that can be utilized. So if that's an area of interest, people can enroll in a gene discovery research program and potentially find a new genetic cause. There can be emotional impacts on the family system, positive or negative, with positive or negative results. So I've seen it where like a lot of people in a certain family are affected, and then one person ends up negative, which is, of course, a happy situation that they're not going to have CMT, but they can also have things like survivor's guilt, that they're not going to live with a chronic disease that their family members have. So it can kind of go both ways on that, and you never really know what to expect in terms of how you're going to react. There may not be a genetic test that's readily available for people, either because of cost or that they need to explore research-based genetic testing, which can take years and years to find a genetic cause. Some people also have concerns about genetic discrimination and how this might affect people's sort of financial futures, things like that. There are federal protections that we have, and this really is more related to kind of broad-based genetic testing, because with broad-based testing like exome and genome, you can find out things that are not necessarily related to CMT, like future risk for things like a hereditary cancer or heart disease. And so most labs allow you the option of opting in or out of that information, because there could be life ramifications on things like your ability to get life insurance in the future and stuff if you find out you're gene positive for like a genetic cancer syndrome. So not necessarily related to CMT. If someone's having CMT symptoms, then that diagnosis has already been made clinically, and defining the genetic cause doesn't really change that. It's sort of just defining what's causing those already diagnosed symptoms. But if you're talking about finding out about future risks, there can be an impact. Cost can always also be something that prevents someone from getting genetic testing, although costs have really come down in recent years. So gone were the days when these types of tests were costing $20,000 or more. And believe me, I was there as a genetic counselor talking to families about these options at that time. They have come down considerably, and now you can even get exome and genome testing very reasonably costs. And there's other issues like, should we test children, and other issues that can come up when you're doing genetic testing in a family that you might find out. Testing a child that maybe is not showing symptoms, is that going to be beneficial to them or not? And are they going to feel differently about themselves if they find out they're going to have a genetic condition like CMT in the future? So we kind of talk to families about whether or not it's the right time to pursue testing. I touched based on some of the research testing options that are available. And through a consortium called the Hereditary Neuropathy Consortium, we do have research testing available through Protocol 6602. So some of the natural history studies that you already learned about from people like Josh Burns, and some of the outcome measures and quality of life measures have all been developed also by this INC network. We've also been helping to identify biomarkers, and importantly, trying to identify new forms of CMT, particularly axonal forms of CMT like CMT2, because we know a lot of people can't find the genetic diagnosis when they have CMT type 2. And then our goals are to be ready for clinical trials and have interventional trials like gene therapy. So in highlighting the identification of new forms of CMT, as you remember, there's so many different types of CMT, but sometimes people can test for even broad-based genetic testing and can't find an answer. So some families cannot find a genetic cause of their CMT through what we call commercial testing or testing that's available in a clinical laboratory. And that's where our gene discovery program kind of takes over. And people can either have genetic testing through the INC. This includes genome sequencing. That's what they're doing as part of that protocol. Or if you've already had genetic testing like genome sequencing or exome sequencing, that data can be transferred from a clinical laboratory into this research platform. And through this process, we've been able to help identify new causes of CMT. The INC has been responsible for identifying over half of the new genetic causes of CMT in the last 10 years or so, including the SOAR gene, which is one of the more recent discoveries. And to just show you kind of how complex gene discovery is, if you were to print out the entire human genome, which this group did, you can see how much data you're really looking through in order to try to find these needles in a haystack, these novel causes of CMT. So in this case, these volumes are color-coded. Each color represents a single chromosome. So chromosome 1 has many volumes, and this is the genetic code printed out in full form. And so this is a lot of data that you have to look through each specific letter and try to see if there's a change that could be causing CMT. And how we do that is we de-identify this data, so name and date of birth, all those are taken off, and we pool it with folks who have other similar types of CMT presentations, and we look for similarities across that population. So it's a very painstaking, detailed process to try to find these new forms of CMT. So I hope I've explained a little bit more about the complexities of CMT and the genetics, and that it's not one disease, so it can be complicated to find the genetic cause. There's not a single genetic test, so there's many types, and that's why people like myself and other genetic counselors help to not only find genetic tests that are right for that person, but also guide them into what that means. Not all tests are the same, and they do change from year to year. So I think the biggest message is that for folks who have struggled finding the genetic cause and they've had genetic testing, it is something that you should continue to ask your neurologist about, that even if you've had testing 2 years ago, 3 years ago, it's worth exploring again. And if you're not finding that there's access through your neurologist or primary care provider, you can always ask for a referral to a genetic counselor who can help guide you through that process. Again, we talked about research-based exome or genome sequencing that can find new causes of CMT, and that's through Project 6602. I also mentioned finding a genetic counselor near you can help, and that can be found on the NSGC website. The Inherited Neuropathy Consortium also has sites that specialize in CMT where you can be involved in the consortium. So if you go to their website, there's a lot of resources as well. So I'm going to stop there and see if there's questions, or I don't know if this is the time for that. But.
Yeah, perfect. Thank you so much, Shawna. That was a wonderful and informative presentation. We did have a couple questions in the chat that I'm happy to field to you. The first question I have for you is, if you had a whole genome sequencing done and no subtype was found, but it was a few years ago, is it worth getting retested?
So yes, we recommend testing repeating testing every 2 to 5 years. And also you should see if the laboratory where you had the test, so not the person who ordered the test, but the lab where that test was sent to, has a policy about reanalysis of genomes, because many labs offer a free reanalysis of a genome sequencing if you've had it within the last 5 years, for example. So that way you don't have to go through insurance again, don't have to collect new samples. You can just, you or your provider can just submit a request for a reanalysis. So it has to be done typically by the ordering provider. And then they can just go back to the lab, request that reanalysis, and the new report will be issued, including any new genes that have been discovered over that last few years that you had the testing. You can look at your report on the top, usually will tell you which lab the test was sent to, and then you can look up that lab's website and see what their policies are. So sometimes these free reanalysis will expire at 3 years. Some labs, they expire at 5 years. So I would encourage you to ask your provider or look at the lab where you had testing and see what your options are, and don't let those free genomes expire.
Yeah, that is a great tip. Good to know. Thank you. So can family members have different CMT subtypes?
So the answer is typically no, with a little caveat to that. So typically you're going to have everyone in the family is going to have the same type of CMT. However, CMT actually is a common neurogenetic condition that it seems like no one's ever heard of, I know, but it is a pretty common condition, even similar to numbers like people who have MS or another neurogenetic condition called neurofibromatosis. So we have, in rare cases, had families that have had multiple types of CMT. So in that case, if someone inherits one type or another, that could be different in the same family, but that's not typically the norm. And then the third reason why people may get described as having different types of CMT is if people, like their neurologist, is using more like a phenotype driven diagnosis instead of a genetic diagnosis. As I mentioned, some of the types of CMT that we used to use, like CMT3, CMT6, those are kind of driven by a clinical presentation and not actually by the genetic cause. And so, and there can be genetic forms of CMT where you may look it up and it might be linked to like multiple different types of CMT. So it just kind of depends on who in the family is seeing what specialists and what terms they use, for example. But we really just try to base it on the genetic cause, which most often is going to be the same in everyone who's affected in the family.
Yeah, absolutely. Thank you. So our next question, my son, who has early onset symptoms and fast progression, has been diagnosed with CMT type 20. His father and grandfather have the exact same gene mutation, but my son's neurologist will not say it's inherited because my husband is not symptomatic. How can we pursue having this linked as inherited?
So I would say that the best thing is to get referred to see a genetic counselor who can walk through that. They'll take a detailed family history and ask questions, and then sort of help to determine how something is being passed on, as well as looking over the details of the genetic testing report and see, why one person has it and another person is not experiencing symptoms. So some of these types of details are missed in a conversation like this that's a little bit more generic. But if you see a genetic counselor or ask to be referred to a genetic counselor, they can walk through those details. There are some rare forms of CMT that we know can be very different from family member to family member, and even people who may not be symptomatic. But I can't say if that's the situation in this case unless I was looking at like the report details, the family history details, those sorts of things. So if you're not getting the answers that you want, a genetic counselor can be a right choice. Even if you've already had genetic testing, I see people all the time just to kind of be more, inform them about their condition and what it means to them and what it means for other family members. So seeing a genetic counselor is not limited to just people who are wanting testing. There are people that also see patients who already have a genetic diagnosis.
Yeah, absolutely. Thank you. And yeah, we have some specific questions always come in, but of course, everyone, we want you to see your medical providers and get that specific information. But just as general topics to discuss, it is helpful having those specific questions. We do have one more question from the chat, and then I will let you go, Ms. Shawna, but it's been such a pleasure hearing you today. How often do spontaneous mutations occur? My daughter has been diagnosed with CMT1A, but we, her parents, have no family history and tested negative.
So that's an interesting question, and actually it depends on the type of CMT. So CMT1A, most of the time comes from a parent, but about 10 to 15% of the time, we see that it is a spontaneous brand new change that occurred, a duplication in that individual that did not come from either parent. There are other types of CMT where that spontaneous change occurs more commonly. So, for example, CMT2A, the spontaneous change occurs about 50% of the time, so much more common than CMT1A. And in part, it is a little bit dependent on the severity of the condition. So more severe forms of CMT have a higher, what we call de novo rate. De novo is a term for a spontaneous change. And so there's genetic reasons for that, but I don't need to get into those details. But anyway, so again, depends on the type of CMT, but there are forms that happen right out of the blue where you don't have a parent that's affected.
Okay, so can happen, yeah. Wonderful. Well, thank you so much for your time and for your support of the CMT and the MDA community, Shawna. We appreciate you being here today. Thank you.
Thank you.